Alrighty. Hi, everybody. I am going to talk to you uh, about stroke and brain injury. And we're going to do this in two separate discussions here. Um, and so a couple things. There's about 20 slides, including title slide references here that give you access to this information. I know it's built upon other information that's shared in this class. Um, and this is just kind of the foundation, the organizational piece of it that links to the accreditation standards. Um, but what I want to do is give a brief intro here. It's going to take me a couple minutes to do it. I'm going to do my best to stay on track. There's so much I want to share and convey here. But remember, we started this discussion. You had cases about brain injury and neuro, and these discussions for these conditions is going to continue, right? If the whole class was about these conditions, and I happen to know these two more so than others, we still aren't going to appreciate everything we need to know. And you don't need to. You need to get the foundations, right? And we'll talk about some of those things. And once you have those foundations, then you can build upon it from there. I'll add in pieces and we'll make sense of it. But I want to appreciate a couple things here. These conditions um, are some of the most researched and some of the most complex. And I don't mean just because it's the brain or whatever. You can have other conditions that create more complexity in different ways. There's things that we miss as OT sometimes and as healthcare professionals. So I just want to make sure that we take some time to address it. So enough of that for now. So we're going to talk about cerebral vascular accident, also known as CVA. Common term for it is a stroke. So with that in mind, you're going to see on both of these PowerPoints several slides that are very similar, about 3, 4, 5 of them, and that's intentional because what happens is with stroke and brain injury, you'll see there's a commonality in how they may present more so than not, or more so what we may do with them, which you'll learn more so after this course across the lifespan with these conditions, but also um, just kind of how they how they present and what we do with them. The mechanisms for what they do, for how they happen, vary slightly, right? The etiology is a bit different. So anyways, here's our objectives. So we want to understand the presentation in this instance of stroke, but the etiology, some signs and symptoms, and other types of relevant information. I'm going to describe some performance skills. You may see that I may not talk specifically about the performance skills, but that's also embedded into some of the readings and some of the other stuff you'll be getting for this content. And just talk about the differences between how this condition can present itself. So this is one of the slides that I said is going to be kind of similar. And you'll see we'll kind of have it be, repeated when we talk about brain injury as well too. But looking on the left side here for stroke, you've got different types of presentations and the explanations. Let's just go over these here. Similarities and differences, and I'll focus mostly on stroke here, left column. So etiology, how can it actually, what happens? That's what the etiology is, right? So stroke could be ischemic or hemorrhagic. We'll talk about that. Compared and compared and contrasted to TBI. Origin of the injury, stroke is always going to be internal. TBI could be external. Incidence and prevalence, there's asterisks here because I'll be referring to these on different slides here. That's all that means. And then now we get into some similarities, left to right hemisphere, short-term, long-term needs, and then we talk about occupational performance so this is where it's going to look very, very, very similar, right? What is your brain hemisphere dominance? What's your hand dominance? What's your occupations? What's your roles? All of those OT things. Well, we talk about them in OT, but they're really relevant across everybody. Kind of comes up in this regard here. And everything else is the same. So that differences is really at the beginning and what we'll go over on some of those upcoming slides. Please note for both of these conditions, even though we're talking about stroke here, that recovery is linked to socioeconomic status, age, risk factors, severity of injury, mechanism, and access to resources, both the short and long term. What does this mean? Here's the thing, my friends. There's no one way to achieve better practice. You can't say, you can try to some degree, and we'll talk about it, but you're not going to have an instance where it's going to be always, I do this with this stroke or this condition, or this brain injury. It's individualized. It does depend. Yes, I went there. But we're getting closer to each step of the way with these classes, understanding how do you decide what depends and what matters, and how do you make those appropriate clinical decisions when you're with a client. So this slide's another one that's going to be repeated over both of these discussions here. So, and I want to talk here is that when we talk about brain injury in this right column here, you have traumatic and non-traumatic. Traumatic is a traumatic brain injury, right? Some kind of trauma, usually external, that causes it, versus a non-traumatic brain injury, which is a stroke. That's just a matter of a medical clarification there. Traumatic brain injury is one subset of brain injury, as we noted, acquired through a traumatic event. Non-traumatic is the other subset, and it includes stroke, but it also could be some type of infection, such as meningitis or encephalitis. I want to take a couple minutes to talk about this slide here. This is for both conditions here. I didn't highlight one CVA over TBI, but we're talking about TBI, or there I go, CVA here, and then we'll talk about TBI in the other discussion. So definitions. Here's the thing. There are explanations and definitions. You will read them. They are what they are, but there's lack of common definitions for certain terms across the board beyond just the condition. And this makes it a bit challenging for us to address, let alone, not just as OTs, but as healthcare professionals to address, let alone do anything more about it. And so for reimbursement and for other purposes, it makes it challenging. The goal here is just to kind of make us aware of it, to add that layer to it. So what does quality of life mean? It's a very vague kind of term. How do you measure quality of life? I asked the question, it's more of a reflective kind of thing at the moment. How about getting back to the community? There is a community entry or community reentry. Is it community integration or community reintegration? All four of these have been used in different combinations. None are entirely wrong. Kind of want to say none are entirely right, but they all kind of have partial truths to some degree. So take a message, just be aware of it, know what the site is that you're working at, how they define this and how they go about doing it, but you're learning the foundations in OT school as to how to navigate this, and that's the most important thing. So this lack of consistent ways to measure and gauge performance and outcomes. Because of this, if we can't define it well, we can't create a measure for it well. If we can't create a measure for it well, we don't know what outcomes are. How is somebody successful? Is it because they're at home and not in a nursing home? Is it because they're at home and not back to work? Or I mean, you can look at so many. That's why, again, it depends on many different variables. And that my point here is consider implications of qualitative analysis methodology. So if we look at quality of life and don't define it by a number, but by what a true quality of life is, that qualitative, that quantitative piece versus that qualitative piece is going to be a bit different. And often reimbursement occurs across the board, more so with adults than with pediatrics, with a number, the functional independence measure, for example, although there's other ones that are out there that you'll be hearing about. But when you reduce it down to a number, it simplifies it, but then does it oversimplify it, especially when there's an inconsistent definition. So unfortunately, I don't have an answer for you. And the roles that I've been in before faculty, as faculty, and other roles we've talked about, been trying to address it, but these things move slowly. So there you go. And I'm doing the stroke presentation here first. So by the time I do the TBI one for you, you'll already come to this slide and that lecture won't be as long, discussion won't be as long. Um, so how do we categorize this? Well, the first one we're going to say is we're going to talk about TIAs, transient ischemic attacks. They're called mini strokes or minor strokes. And then, we've had discussions as to what is a mini stroke or a minor stroke? Is any stroke really minor? Oh my goodness, I had discussions with people about that. And there's no exact measure anywhere, not even just in the United States, as to defining this. But a key aspect of transient ischemic attack is that there's no lasting issues across the board, even with occupational performance usually, but even medically, it clears up. Could be indicative of other disease and other issues moving forward, but for the rest of the strokes, though, 87% of all of them are ischemic. We'll talk about that. About 13% are hemorrhagic. So you're often going to see a more hemorrhagic, you can see it, ischemic type of stroke. I'm showing you three different ones here, and I'm going to I have the abbreviation, but I'll explain this here too. These are three of the more common types of stroke. MCA is middle cerebral artery. I do realize that in neuro, I think even in your movement course, we're not talking about the circle of Willis, but if you were to look at the circle of Willis for blood flow to the brain, 4 arteries on either side, so 8 total of them in this circle. The middle cerebral artery addresses the most. It kind of comes to most parts of the brain, on whatever side that is. And so it can do the most damage. And so if you have an ischemic stroke, a middle cerebral artery is left or right are the most common. And so it's one of the more common types of stroke. It's also one of the more debilitating as well too. And there's a certain way that they might be able to present and talk about that. ACA is anterior communicating artery, or in this instance, well, there's two. There's the anterior and the anterior cerebral artery. For this instance, we'll talk about it as the anterior cerebral artery, and this is in particular going to affect and impact and give us a result of aphasia or apraxia. Aha. So we started this discussion about praxis, and then the lack of praxis, or in this instance, the lack of the ability to talk. So not only does it occur with an ACA CVA, but in particular with an ACA CVA, you can start to identify that. You look on a chart, you're going to almost gauge this is going to happen. Okay. And then PCA is the posterior communicating artery. And you have confusion, memory loss, and paresthesia, sensation issues. And it's important to note the sensation issues are how the brain interprets sensation. So there's no problems with our sensors, with our touch sensors here in our fingers. They're intact. It's the issue that's in the brain. And so, like everything else we've said in neuro holds true here, is that in order to help that get better, you have to retrain the brain to be able to do that, right? It's not improving sensation here. Sensation's fine. The brain's the issue. So there's your categorization. Incidence prevalence with the incidence and prevalence with adults. Third leading cause of death. I put this in red because I just was reading as of this week, I think, in early mid-December 2020 here, the COVID-19 has surpassed and changed how this numbers have started to play out. So although this is still leading cause of death, people still have strokes. All this stuff still happens. COVID's kind of thrown those numbers off a bit here too. It is still the leading cause of disability. There's more than 800,000 new strokes annually, and most of them are survived. So 700,000 of strokes people with strokes will survive. There's over 9 million or so total stroke survivors. There's a lot of people out there. That's what I mean is when I talk about this, it's the most common condition you'll see. Most of you will treat this in some regards. But there are controllable risk factors. And I covered this also in another slide, but I just wanted to kind of show it here. Primary indicators of outcome, age, and socioeconomic status. I want to point out here as I briefly mention on that comparison slide on the other slide is that the younger you are, the better outcomes there are. There's no exact age here, but less, let's say sometimes less than 50, but it's kind of depends on how you kind of look at those numbers. But younger has better outcomes. And socioeconomic status for a number of reasons, in particular, access to services and access to healthcare. This becomes a huge predictor of outcomes, not necessarily because accessing therapy, you can have access to therapy and have it be the worst therapy, right? And then there's natural recovery as well too. The issue is that the amount and volume, right? Kind of think back to the final exam question on, well, actually, no, I'm jumping ahead. That's not something you've had yet. There's a exam question that I've set up a link to something that talks about a future course that talks about access to resources there and how might it impact an outcome. But nonetheless, that's something to keep in mind. Other risk control factors: diet, weight, obesity, smoking, blood pressure, heart health, right? These are all things that you can control and minimize your risk. And another thing to just point out here is the cost or benefit of health promotion versus persons living with stroke. Latest numbers, and I'm sure this changes, is about 34 billion from the resources that I've seen. So if you teach somebody to be healthier, and not just individuals, but populations, communities, you're going to save money, right? So it's a big deal, right? But easier said than done, but nonetheless, that remains true. We talk about children with this here too. We have about 2.5 cases per 100,000 of children per year. So much less frequent, but it does happen. And it happens more in children younger than 2 years of age. Most common cause is genital defects that affect heart structures that cause impacts here. But the results are still the same. Age is on your side. You can grow into any remaining disability, but that's it. So a little bit comparing and contrasting there. So we talk about risk factors. This is I went to this list a little bit more here, and just want to talk about it briefly. Is that these risk factors on the left can be controlled. So contraceptives, heart disease, inflammation, alcohol and drug abuse, sleep apnea, which causes types of breathing type of issues with the heart, obesity, hypertension, which is high blood pressure, smoking, and diabetes, as diabetes mellitus. These are all controllable to some degree. Again, the reality of life is a bit more complicated than that, but they are. High lipids, hyperlipidemia, having a prior stroke, ethnicity, heredity, age, and even where you live, to some degree, because you can move, but may not always be possible. Those are less controllable kind of risk factors. When we look at what's called the stroke belt, the darker, I tried to make this a little bit bigger, but you can look it up online, and I'm sure there's a newer version of it. I actually didn't pull it up for this one, but that dark purple is the higher incidence, the higher number of rates per capita of population. And it's in this center, middle, southern, what they call the stroke belt. Part of it is access to resources. Part of it is the age. Part of it is your diet. And so that's actually a reality there. So just an interesting little side note here. It looks like when I did this, I kind of covered over part of this, but different way to look at what we talked about in neuro. And if you remember in neuro, we had that left and right hemisphere kind of thing. It's just another little similar slide to kind of hold on to: left hemisphere, right hemisphere. I'm not going to go over these here. This is more of just so you're aware of it. We talked about a lot of these. And neuro, I don't think there's much to kind of add here. In fact, we looked at it slightly a little bit different. We did not talk about production of dreams with right hemisphere or musical stimuli. So those are new in the right hemisphere. We did talk about expression of emotion and stereognosis. So again, take a look at those on your own, and then categorize that accordingly as you need to for this course. But please know that there should not be anything new here. I kind of like the graphic here showing the left organized and then the corpus callosum crossing over and then the more artistic side of that right hemisphere. So again, that's nothing should be new with that. Just have access to that and just refresh our minds. So we start talking about different types of strokes. As I said, we've got thrombotic strokes, and that's what we'll talk about next year. So thrombosis is a clot, and here you can better see kind of the circle of Willis and that center piece there that I was referring to, and you can start to see when you look at, in particular, say the middle cerebral artery. I don't know if you can see my cursor here, but it's in the middle part off to either side. It affects much more part of the brain. Right, this is just looking straight on versus inferior from top down or another angle or lateral. So it occurs more frequently in vessels that have been damaged by atherosclerosis, more common, and the larger vessels that account for more than 60% of ischemic strokes, right? So the more common type of strokes are related to aspects that you can control with your health. If you can decrease the plaque in the arteries. And it's more likely to occur where blood vessels turn or divide. In that instance, they go from bigger to smaller. It's like a highway, right? If something gets caught there in that instance, that ends up causing that clot and can cause damage after the fact. Versus an embolism, it's the same photo here, just talking about slightly different. This is a clot that breaks off and then travels up and reaches to an artery too small, blocks it off, right? And that occurs, the cardiac source, the emboli here occur in 20% of ischemic strokes. You can have with certain cardiac abnormalities, which is what they look for, and you might see in a medical chart, medical history kind of thing, as atrial fibrillation, coronary artery disease, valvular heart disease, and heart arrhythmias. Now, those are not parts of this specific discussion. I think they intersect some other condition discussions, but just so you kind of have an idea, this kind of gives you more of a global kind of picture of the condition here. You can also have intracerebral hemorrhages. You can kind of see what's going on here with this particular one on this left side here in this graphic. You see that blood begins to fill. So you have a hemorrhage, you have a bleed from one of these arteries, and it fills that space. So what ends up happening is that bleed into that space then causes it to swell. And you have secondary tissue issues when that swelling presses against healthy parts of the brain. So it's more diffuse in that regard, and it's hard to kind of gauge. It's not going to be a specific type of hemorrhage. A bleed is going to look different than a very specific type of clot that leads to a very specific type of injury. It can occur anywhere in the brain, usually linked to hypertension, high blood pressure, HTN. And the causes are different abnormalities in blood vessels. Arterial venous malformations, AVMs. People are often born with AVMs, these malformations, and they can put people at risk because if they rupture or if they damage, then or if they're repaired, they can still cause a stroke, and sometimes people will do that. Aneurysms, a clarification here is that you might hear, if you've heard in the movies or whatever, somebody says, oh, I've had an aneurysm. Well, you could have an aneurysm. That technically is this a version of a malformation here of sorts. When that ruptures, when you rupture an aneurysm and have that bleed, that's actually more accurate. A little detail, but and of course, trauma can cause these types of things as well too. I had a visual on there, and I don't remember what that was about. So that was looked like Lucille Ball. So we'll leave that there. Subarachnoid hemorrhages. So this is similar, but its presentation is in the arachnoid space. So it's a bleed between the space. If you can see, it looks a little bit different here. that causes swelling between the skull and the outer area and the actual brain tissue itself. And so let's read about what I have here. Bleeding occurs within the cerebral spinal fluid, within those membranes, the dura and pia mater, and CSF, cerebral spinal fluid, more common in women, and causes our leakage from blood aneurysms. Mentioned what blood aneurysms are. This is most of it, 95%. The AVMs, the atrioventricular malformations, hemophilia, too much anticoagulation therapy. So coagulant makes blood not dissolve, makes it coagulate. Too much of the anti makes it then just the opposite, causes bleeds. And then trauma to the skull and brain, which intersects a little bit of how I've defined brain injury, but nonetheless, this remains true. So when we talk about some specifics here, I know as I said, it's hard to categorize, and it is kind of hard to categorize. We can talk about this just a little bit. If we have a middle cerebral artery stroke, and we talk about left-sided cerebral injury, we can talk about certain deficits. So if somebody has a left MCA CVA, you may see this. Now keep in mind with asterisks, with caveats, and all the usual, it depends, could be anything. But you can start to at least hypothesize about this. So you're going to have right-sided hemiplegia or hemiparesis. Plegia is weakness. Paresis is paralysis. So one-sided weakness or paralysis. Right-sided hemianesthesia. So this sensation type of thing is going to be impaired. You could have aphasia. So remember, aphasia, A before it means not. So not being able to talk. But it's not so much this, it's more of a term, right? It doesn't mean you can't talk. It's just how it presents. So you have Broca's aphasia and Wernicke's aphasia. Broca's occurs in superior division and the Wernicke's in the inferior. The difference between these is that they are fluent or non-fluent aphasias, meaning, and I try to do this, but a fluent aphasia is going to be something that flows fluently. But it doesn't make sense. So it might be something like, I'm looking around my desk here trying to get an idea. Green, purple cup, mask, keyboard is what I say. It was relatively fluent. But what I thought I said was, I'm not sure it's light enough in here. I don't know, something like that, right? And so the issue is being able to then make sense of what's being said, which could be frustrating for the speaker and the listener. Versus a non-fluent aphasia is going to come across a little bit like this. And you're going to have some type of, it's not fluent, and it may or may not make sense. Again, a bit challenging. Is where speech language pathology colleagues can really be helpful to help us understand and help address it. And we can help with communication boards and other aspects. Dysarthria is the ability to motorically, orally have our muscles do what they need to do for speaking, for talking, for swallowing, for eating, masticating, chewing. So these things could be, and there's that related information with that as well too, just to know. You can have those blind spots we talked a little bit about in neuro, and it would be in the visual field, usually on the right side. So you have a visual inattention to that right side. The person might present to be slow and cautious because they're not so quite sure that they understand or you understand them, and they could have memory deficits. Versus the right side of the same type of stroke, the MCA stroke is that you have actually a lot of the same type of things, but I want to point out a couple of differences here. You're going to have those spatial and perceptual deficits and the neglect. So you're going to have a visual inattention on the left side, as well as a visual field cut. So your brain's not seeing part of what actually it's not being processed by your eyes. What comes in through your eyes not being processed in the occipital lobe. So as a result of this, you have lack of attention, and lack of actually seeing, actually a visual field cut. And so that is a neglect. Um, and that's combined sometimes with this homonymous hemianopsia. This is where you have the same side of each eye being affected. So if it's the left side, it would be my left. I know it's the mirror view, so if you're looking at the video, it would be the lateral side of my left eye towards my ear, and the nasal or medial side of my right eye, right? And so that is the issue. So then it's going to be affecting what I can see, on top of the fact that I may not be able to process it. And you might also have somebody that presents as being impulsive. It's that term we talked a little about in neuro, but the idea of being impulsive, where they may act because they're not aware of their deficits, so they're going to think that everything's okay, that sensation's intact, that they can do more than they can, right? So that kind of is how that would look. I just wanted to point those out because they're the most common, but just to kind of give us more of an idea there. So when we talk about stroke throughout the lifespan here, this remains true. Just a couple take-home kind of things. There could be so many details, and I wanted to give you some details, but I want to have a larger discussion just to kind of share with us some of the nuances, because you're going to build on this in future classes. And I got to point out here is that when we talk about the lifespan in these conditions, it really is not about fixing them, right? In many instances, people don't recover entirely, other than those TIAs, from either of these conditions that we're going to be talking about here. And so that could be how you interpret. That's up to you. You know, I'm going to stop short of saying that, but I've got to tell you is that a lot of the evidence says is that we support people to adapt and adjust and compensate depending upon how we do that. Like as healthcare professionals, with OTs in particular, this is our, I want to say, bread and butter. This is what we're good at. This is one of the things we're good at. And so it's understanding those nuances. So with that in mind, if we look at this from a developmental aspect, children who acquire brain injuries in particular, actually stroke or traumatic brain injury, will continue to grow, and they will have an opportunity to revisit those residual deficits. So they may end up growing into their injury, but they might have soft tissue issues, right? If you've got that tightness, even if they don't use that limb, that use or not use kind of thing, it orthopedically is going to affect it over time. So in doing so, it might have to be addressed over time. So just kind of keep that in mind for your pediatrics courses in particular. Education. Across the lifespan, especially with children here, they may be eligible for services through the Individuals with Disability Act and Education Act from 1990. Modifications can be requested through individualized education plans, IEPs, to integrate or include students into the classroom. Modifications can be requested at all levels. Now, we talked about this a little bit in neuro, and what would you do for this kid that wants to go back to school? And you might know this from your own experiences as well. Self-care, we do a lot of this with OT, right? And all across all levels of care. But it could include not just having them dress themselves or feed themselves the correct way or getting it back to being independent or normal, but how do you combine things such as strategies? When we talk about cognition with strategies, how do you teach the person, the client, or the patient strategies, and or caregivers or family members? Decrease the amount of steps, give less clutter, do this, do that, whatever that is. How do you modify things or give them equipment or even have personal assistants help out as a way to kind of affect that in the short and long term? And it's good for us to think about that long term, even if we're at the front end of things. And then work, returning back to work if somebody's at the working kind of age here. There's neuropsych assessments that occur that are not contextual, but they do kind of tell us certain aspects of how the brain is kind of working. Any modifications, like modifications to the workplace, reasonable accommodations for return to work, RTW, just like we talked about a little bit in neuro, we're just building on it a little bit more, as well as with Americans with Disabilities Act requirements, like what's required by the law, by this act in each of the states, the state of Illinois in particular, since that's where we live, but wherever, and how does this fit together? So there's a lot of things. There's a lot, right? and it's all equally important, but just in different ways. So there's all kind of ways to address both of these conditions. But again, we're talking about stroke at the moment. So I want to mention here while we're talking about this, resources for you to consider. This discussion can't stand alone. It has to exist with other references and resources and stuff. So neuroscience for occupational resources, some of the structures and functions which we really didn't talk about, right? We didn't talk about it, and yet, you know, that's okay. I think to some degree, you can discuss how you feel about that, but the structures and functions. But then we talk about the systems as well too, the autonomic nervous system, limbic sensory motor cognition, right? Visions in there as well too. All of those, now this builds on that. You can start to see the layers maybe peeling off or adding to each other to help us kind of understand that. If I have a left MCA or right MCA CVA, I not only can expect what we started to talk about here, but I can also start to imagine how it can impact and affect all those other things that we talked about in neuro. So we start to have this really complex potential representation of how an individual looks so that we can have an idea. We can definitely take information about populations and such from the references or resources or evidence that's out there, but it's only going to take us so far. There's the AOTA cognition statement. I mentioned this in neuro. We didn't come back to it, and that's okay. And I'm not coming back to it at the moment. I'm re-referencing you to it. It's a longer type of document and probably going to be more relevant if it doesn't come up in conditions to your OT process and practice courses for pediatrics, adults, even psychosocial. And that is, and I share this here, OT does have a role in cognition. And we always hear from students, and likely going to happen to you too, where there's aspects of cognition that impact and overlap with speech language pathology. There's role delineation, same thing with other issues with OT and physical therapy. But in this regards, we have a role in cognition. Remember way back in our cognition lecture, one of the first things I said is that when cognition issues impact occupational performance, the way we define them as a profession, regardless of how things are reimbursed, again, longer, deeper discussions for another time that we'll build on, then it's relevant to OT. Doesn't mean we own it. It just makes it more relevant. Our rules are. There might be times where it's not. I've had people that I've worked with, and give an example, right, that they're able to perform their daily activities. They just have issues with being able to communicate or address certain types of cognitive type of things, but they're doing fine from an OT perspective. Then I don't need to see them, right? But you got to look at the document. I can't summarize it. It's its own multiple lecture type of thing anyway. So you just got to look at it, and just, it's a good reference to kind of hold on to. And then there's stroke documents, and there's many, many, many out there. AOTA has documents. There's as many things out there about this condition as you could think about. But I want to point out the Carolyn Winstein 2016 article. This is the adult stroke. This is adults in particular, but the adult stroke rehabilitation recovery guidelines. These guidelines are being turned into more specific standards that might be addressed down the road. And this is some of the work I've been doing with the American Heart Association related to this. But these guidelines, again, a huge, great resource and document. It takes you through every aspect of stroke management. The best reference out there to this day. It has 973, almost 1,000 different references within that document, but it's the best of the best of the evidence to this day. I highly, highly recommend it. This is all the stuff that it talks about. Look, it covers everything that you could think of. It doesn't tell you how to do OT, right? But it is a good reference for all healthcare professionals. It should be a foundation. So again, you got to come back to that on your own. So consider that. And then return to work and return to driving. I have an asterisk here, and I have it in red because this is some of the work I've been involved in. I don't have the readings here for you. We can always provide this to you. When we talk about minor or mild stroke, I've been part of some groups with the ACRM work that I've done with. And we published related to helping us understand and giving strategies for returning back to work and returning back to driving. These are brand new references, more cutting edge than not. And again, as the time I've done this discussion, this recording here, I was not going to provide it, but I definitely could. It's more of a guideline at this point in time. There's still work that needs to be done, but this is kind of an overlap and linkage to the idea of the mild injury um, and minor injury, trying to understand that and defining it, making sense of it. So these resources, I'm going to similar with different ones on the TBI discussion, are some of the ones I just want to put up here that you've got able to. And there's an overlap here. This is CVA, but we're talking about brain injury a little bit. There's a brain injury model system. It's a system of care, healthcare. It's just guidelines that go through, and hospital systems could be part of that. If they are, then this is what they follow, guidelines, federal guidelines. Stroke Engine's a great resource. It has a lot of assessment measures within and outside the context of OT. Really good reference. This next piece talks about traumatic brain injury and links to your readings with that, but the Ranchelos Amigos level is a good education chart for patients. This is our family members. And the Mayo Clinic is a great resource. Their online resources are excellent as well too. There's the web link for stroke and the web link also for brain injury. I'm not going to necessarily go over this here, but I want to kind of pull this back up here. Your embedded case that you have is that these are the questions you kind of can think about here. And this is really the next step of how you need to kind of piece this together is that, ask these reflective questions. It starts with this, builds upon what you learned in the fall quarter. What occupations are affected? What skills are affected? How does the condition present? Get used to the exercise to kind of do this, right? What are related disorders and risk factors? What are the body functions that are impacting this, right? So being able to understand and define and link this as an aspect of our doctoral education. It's an aspect of OT education in the United States. But even when we get down to body structures, it allows us to kind of then define and refine it and say, this is how I go through all the it depends to decide how do I do what I do with OT. And I got to tell you, from the stroke aspect, what OT should look like from all the evidence that's out there is engagement and occupation, right? Not fixing some of this other stuff here. And again, we can agree or disagree or have different perspectives and discuss another time. But I've had students ask, I've had colleagues ask, I've taught versions of this around the country and around the world. And I'm by no means an expert, but in how I understand the evidence, and I invite you to learn it as well too, is that not just for OTs, but for OTs in particular, at all levels of injury, OT should look a certain way. Now, if you go back to OT with stroke should look a certain way. If you go back to week 10 of neuro, we had Marissa Vavra come up and she gave us more of a specified kind of categorization. That's a good cross-reference here to have us to kind of use it just as a living resource for us, the breathing documents, so that they can kind of help us move forward and stuff. So I'd ask you to do that, but you got to look at it, right? I can't say I can't give it to you. I'm giving it to you, but you have to kind of fit those pieces together. I find that's kind of one of the best ways to immerse in that on this guidance type of thing. So here's a number of the resources that I've had, not all of them, but a number of them. And again, there's so many more. And I'm looking at some of these references here, just a lot of really good stuff for you. So for now, I'm going to leave you with this and just use this as a good foundation. And remember, the story will continue with this condition with brain injury as well as you head into your process and your practice courses next year. And you'll be well prepared for, yes, a little bit more than a year from now, your level 2A fieldwork. So, all righty, I think that is it.